All right, welcome back to Daybreak on this 19th day of May 2020. It's now 7 minutes going to 7 o'clock, and joining us this morning is Dr. Rosemary Sang from the Kenya Medical Research Institute. And Dr. Sang works at the Center for Virus Diseases there. And good morning, Dr. Ari. How are you keeping these times of coronavirus?
Good morning, Sam. I'm doing well and trying to stay with the new life that COVID-19 has afforded us.
Right, and obviously your role at the Kenya Medical Research Institute is pretty important. I mean, if you could tell us, how has been your experience? Because since the start of the year, the conversation has been around testing, establishing who has the coronavirus, but also trying to understand how the virus is changing over time.
Since the first case was detected in the country, it has been just rolling up and speeding up everything and getting everybody on board to facilitate the response that is necessary. The lab is very important because unless you know what you're dealing with, unless you know where the disease is, then there isn't much you can do to control it. So it has been like a roller coaster.
Right. Now, one would only imagine. Has anything changed based on how you tested for the first instance of coronavirus and how you're doing it now, scientifically?
A lot has changed, I would say, because initially when we started, you remember even, I think at some point, initial samples were sent to South Africa. What has changed since then? We had fewer platforms to work with. We were using one particular kit that was initially came from Germany, but we have subsequently rolled up new diagnostic capacities, even in terms of platforms. So, like right now, I think there are different labs using different platforms and different kits, but achieving the same goal, the same results. So it took a while to really get everything going and ramping up the testing so that we are able to deal with the numbers that are required in the response. So at this point, from where we started and we were only using one platform, I think there are now like 5 different platforms, different testing capacities that have been ramped up. You have noticed also that we are no longer just testing in Nairobi. This has been rolled out around the country, and the testing is improving day by day.
Right. And obviously, so many samples get to your facility, including from different parts of the country that do not have labs to test. Are you the ones that are in a position to collect these samples, or sometimes you have to use third parties to do that for you?
The ministry and the response task force has put in place systems. There are teams that go out collecting samples that are made up of individuals from the Ministry of Health and KEMRI and other organizations. So there's a team that does sample collection that was trained as soon as the disease got into the country.
Right.
Of course, there's always these types of work going on. We have always had influenza surveillance going on, for instance, in KEMRI, and the Ministry of Health, the National Public Health Labs, which involves taking samples in a similar manner. So it was a matter of training more people to get involved and ramping up the testing.
So far, do you feel comfortable with the integrity of the sample collection procedures? Because certain labs you'll go and they tell you because of quality considerations, they have to do the sample collection by themselves. What are your concerns at KEMRI?
Initially, of course, as people were learning, a sample is as good as the way it was collected, and that's how you get a proper result. We are improving on that from day to day. More people are being trained because as you begin to spread and widen your scope of capture and population sampling, then you need more people. You have to train additional people, and it takes time for once to get used, yes.
There are certain concerns, especially if you look at the East African region. There are some countries that have been saying that they are afraid that some of the kits they're using could give them false results. There has also been concerns in Kenya that you might be using, you might find yourself using kits that are not up to standard. How do you confirm a positive case so that now we have 912 confirmed cases?
We do not simply go out there and pick up any type of testing kit that may be touted in the market. We are following the WHO guidelines because WHO has identified reference labs around the world that validate the testing kits that are rolled out for use in the outbreak. So we are going by the WHO guidelines in terms of choosing the type of kit that we use, and we believe we are using the best.
And there has been donations into the country, including from billionaire Jack Ma. Have you been able to use the kits that were supplied?
Yes, Jack Ma's kits, they are okay, and they have been approved. So, in fact, that has really helped us to ramp up the testing.
Okay, all right. And so let's get back to that question about how you confirm a positive case. Just take us through the procedure. Is just one sample and one testing enough to confirm that so-and-so has the coronavirus?
So we have testing platforms in the different labs that I indicated about. And when you set up a test, you start with the process of extracting the viral genome. The RNA that is in the virus, that's the one that tells you that the virus is in the sample. You extract it and then go to the step of amplifying what is there to make it possible to visualize and to see it using the tools that are there. And we always set up tests with controls. You don't just run a sample by itself. We set up tests with controls so that if your control shows up positive, it's supposed to be a positive control, then you know that your test works. If it didn't, if your positive control doesn't show up, then that test is not valid, and you have to do it again. So we have control systems that ensure that we pick positives when they are there.
Right. And are you able to pick out the viral load? Like, let's say this patient has this amount of virus in the system, this one has less, so that it may also assist in knowing how much of treatment is required?
Yes, the platforms that are now being used, all of them are able to establish the viral load. Some of them not exactly the number of viral particles, but we are able to establish that there are some that you do a test and the viremia is high. There are some that you do the test and the viral load is lower. It is possible to estimate, I would say, the viral load using the platforms that we have.
All right, Dr. Help us understand, because the government tells us that we have an installed capacity to test of 37,000, but if you look at the effective tests that we've been recording, they're just slightly above 1,000. I think the highest was the day before yesterday when over 2,000 samples were reported to have been tested. Why do we have the difference between installed capacity and the active testing that you're seeing?
Having capacity is like saying I have enough capacity to test so many samples because you have the necessary reagents, you have the necessary supplies, and therefore that is, you can be able to fill your machine with the samples as the machine can provide. But sometimes that is not the case because you may not have everything that goes into the testing of one sample. And as you are aware, from time to time, we have had issues with certain supplies, certain reagents not being adequate. So it is one thing to have a certain level of capacity, but it must also have, you must also have all the necessary supplies that you need to be able to fill that platform with all the testing that you have capacity for. And also, you can only test the number of samples that you receive. So we've been testing all the samples that come.
You don't have any backlog?
There's no backlog. We arrange as they come, so we don't usually keep backlog.
Okay, and therefore, after one tests positive, of course, they are taken into an isolation and treatment ward. Then they are observed, receive the treatment that they are subjected to by their doctors. But then again, it comes a time that they have to be tested whether they have healed or they have recovered from the virus. How do you go about it to ensure that truly the person you're discharging from the wards is COVID-19 negative?
So it's the clinician who makes the decision at what point that the patient that had tested positive should be retested again based on the clinical evaluation that they perform in the treatment center. And the rule is that at that point when the clinician feels that this person is recovered and we need to establish whether he's negative, a sample will be sent to us in the lab, and we are able to confirm whether or not he has cleared the virus. And when we get to that level that one of the first sample tests negative, we must confirm that by the clinician must send us another sample, at least within 24 hours, to reconfirm that, again, that patient has tested negative. So in total, a patient who tests negative, who goes into the treatment center will undergo a total of 3 tests. The first test to establish they have infection, and then 2 tests that must be negative before they can be discharged, at least a minimum of 3 tests.
Have you had instances where the clinician determines that a patient needs to be retested, but then they still test positive despite not showing any symptoms at that time?
I don't have details about that. That is a possibility that can happen.
Okay.
As I told you, it's the clinician who evaluates the patient to establish at what point they should be retested to determine whether they have fully recovered. But of course, if you continue to test positive, you will be retained and managed until you test negative.
Okay. And Dr. so far 336 people are said to have recovered and discharged from the isolation and treatment wards. How safe are they? And once they have recovered, what is the possibility of recurrence of the virus in their body from your study and research?
That is something that will have to be explored as we go forward, and I'm sure the task force must have been discussing that issue, and there are plans for, there have been the contacts and information about all those who have recovered have been maintained. I'm sure they'll be followed so that that can be established. This being a new virus, we don't know what to expect going forward. These are things that must be explored as we go forward.
And therefore, Dr. the government has a target of testing 250,000 by the end of June. Obviously, if you look at the trend that we have recorded since March 13th, or even since the year began, it will take a miracle for us to achieve that milestone. Where do you see ourselves? How many more can we test by June 30th based on how the disease is progressing?
I think we are preparing for ramping up testing. but that has to be accompanied with sampling that will meet those numbers. The capacity is there. Capacity to test is there. That is for sure. KEMRI alone has got 10 different labs that have platforms that can handle up to 20,000 samples. So the capacity is there, and this will be achievable. But considering all things being perfect, that we have all the supplies that we need and all the reagents that we need. I believe, I'm confident things will get better in terms of rolling out of the supplies.
Would you know the stocks that we have now that you're using to test? How many tests can you do based on the stock we have right now?
I was talking to a colleague yesterday. I'm not sure about what is available in KEMSA and the government supply chain. But in terms of kits, I was talking to a colleague yesterday, and I think at this point we can test, we have enough to test 31,000 samples.
31,000 samples. And what is the status? Because I believe it was in April, we had been told that KEMRI was working on homemade or locally made testing kits. Are they ready now? Have they been approved for use?
Oh, that takes a while. That will take a while. People are working round the clock. Developing a testing kit is not something you do overnight, because you don't want to come up with something that will not pass the test of time. So we are using technologies that have been used in the past to come up with something that can test like at point of care. And that has to be evaluated thoroughly, and then it has to reach validation stage. And after validation is when it can be approved for use. So we are still a long way from that.
Right, and finally, so far we've been seeing that the samples that we've been testing are those that have come from government institutions. If a Kenyan decides that they want to be tested and they do not have necessarily to go for the targeted mass testing, what can they do privately? Can they come to your labs?
Privately, we prefer that people follow these channels that have been set, because if we don't use the channels that have been set, then it becomes haphazard. You may find yourself with a lineup of people in your testing facility. The sample taking is separate from the testing facility. So we don't want to encourage people to walk directly into labs. But there are private labs that allow you to drive in, like the Lancet lab. You can drive in, they take the sample and they test you and send you the results when it is ready. But for the government labs, I think they are laid down procedures for accessing testing.
Interesting that you should mention about Lancet, and allow me to ask you this, because yesterday we had a story of how Somali embassy is intervening to have their citizens tested at Lancet, but then Lancet management says that those that have tested positive, they don't see those numbers being accumulated into the numbers that are being reported by the government. How does that work? If a private lab does a test, how is that tallied with what the government is announcing?
Ideally, all tests that are done in country should be submitted to the government. But I haven't read about that situation that you have described. I think I saw it in the news just like everybody else. So I really can't comment on it much. Really, all testing should be reported centrally.
So does that mean that KEMRI is not the only lab that is feeding the government numbers?
Oh no, we have many labs that are generating results.
Okay.
And we have labs. We have the National Influenza Center, which is a government lab. We have the HIV National Reference Lab, which is now also doing COVID-19, which is a government lab. There's a lab at Kenyatta National Hospital. KEMRI is just one of the institutions that that is doing the testing, and we have platforms and labs in different parts of the country. I think also Nairobi Hospital has announced that they have testing capacity. So there are other labs, and that's why when I give you a number like what I said KEMRI could do at this point, that does not include what all those other different labs have capacity to do. So the numbers will rise going forward, and will continue to go up. Yes.
Okay, all right. Thank you so much, Dr. Rosemary Sang from the Center for Virus Research at the Kenya Medical Research Institute. Thank you for speaking to us this morning to share insights on what's happening with the testing procedures.
Thank you. Thank you for inviting me.
All right. Of course, she works at the Center for Virus Research at KEMRI. And after the break, we'll be talking to Dr. Momo Nzao. He is a governance and national security expert. He'll be talking to us about the situation that we're seeing ourselves in the East African region, where we have seen that President Kenyatta has closed the borders of Kenya with Somalia, Kenya with Tanzania. We're also seeing a situation in Tanzania where President John Magufuli says that the virus will come and go, but the economy should continue to be managed. But at the same time, we heard from a provincial commissioner from Tanga saying that all vehicles that are carrying luggage or cargo that get into Tanzania, if they're destined for Tanzania coming from Kenya, they will be turned back. We'll be talking about what does that mean in terms of the foreign relations between the two nations back after this break.